Welcome everyone to this webinar on managing prediabetes beyond guidelines for better outcomes organized by Agency for Care Effectiveness, MOH. So as we can see from the outline shown, most of this webinar will be in a panel discussion format. We will address questions that you raise through the Q&A function, as well as those that have been raised at registration before. Our panel discussion today will discuss sequentially on 4 aspects of prediabetes, as what is shown on the slide, from diagnosis to lifestyle intervention, pharmacotherapy, as well as follow-up. So do feel free to send in your questions related to the aspect being discussed in real time through the Q&A function if they are not covered already. We will attempt to address as many questions as possible and seek your understanding if we may not be able to attend to all. Next slide. So just a brief introduction of myself and my panel members as well. I'm Dr. Darren Seah, a family physician from National Healthcare Group Polyclinics, with a keen interest in diabetes, and I've sat on several committees as well as chaired this particular appropriate care guidance on prediabetes. With us today is Dr. Khoo Meng, who is Senior Consultant Endocrinologist and the current Head of Division of Endocrinology at NUH. He has a joint appointment as Assistant Professor in the School of Medicine NUS. He is a clinician at heart, always looking to better care for patients with diabetes mellitus through education and translational research. And his research interests are in the understanding of the physiology of obesity and diabetes mellitus. Our second panel member is Dr. Abel, who is Consultant Endocrinologist at Abel Diabetes, Thyroid, and Endocrine Clinic at the Mount Elizabeth Medical Center. Dr. So was previously Consultant Endocrinologist at SGH, where he initiated the pre-Ramadan counseling program for Muslim patients with diabetes in 2011 and co-ran the Gestational Diabetes Joint Clinic together with the obstetricians. Dr. So was also the previous Vice President of the Singapore Association for the Study of Obesity. So welcome to both of them. Before we start the panel discussion, I thought I would just give a brief introduction and perhaps set the context for the webinar today. Next slide. So as this slide shows, and this is really, I think, the look at prevalence worldwide from the IDF, and we do know that nearly 1 in 10 adults in the world have diabetes for adults aged 20 to 79. Yet 4 in 10 adults with diabetes remain undiagnosed. And indeed, 1 death occurs due to diabetes every 5 seconds. So this increasing burden of diabetes continues to occur. Next slide. And even in Singapore, and we have already launched our war on diabetes since, I think, for 5 years now, yet based on the recent National Population Health Survey 2020 results, we continue to see that there's a slight increase in the prevalence of diabetes, as well as the rates of obesity continue to rise. Next. And if we look in depth more at the NPHS 2020, we will see that the associated conditions and risk factors like hypertension and hyperlipidemia have increased in prevalence from 2010 to 2020. 1 in 10 Singaporeans now between the ages of 18 to 65 have impaired glucose tolerance. And we also know from our studies that really the risk of diabetes mellitus is 5 times higher for those with IGT as compared with those with normal glycemia. Next. Sure. So I always also want to remind all our attendees that in Asians, we do know at least that really diabetes is not as linked to obesity as our Caucasian counterparts. And from this slide, we can see that really in the US, while they have a high prevalence of people who are obese and overweight, the prevalence of diabetes is not exceedingly high in the US, and we actually have higher rates of diabetes, even though our population has less of the overweight and obese population, right? And this is also the reason why we take a sort of a lower threshold to consider those at risk of obesity-related conditions, right? And most of us, we will use a BMI of 23 to start to think that people are already at risk of obese-related problems. Next slide. And one of the common questions that we thought that we would address just with this slide is really, is there a difference between IFG and IGT? And from this recent meta-analysis, I think it can be said that number one, both IFG and IGT do give rise to an increase in all-cause mortality and cardiovascular events. But of course, this is just found in greater proportions in those with impaired glucose tolerance as compared to IFG. So IFG is also a problem, but indeed IGTs appears to provide a greater risk of all-cause mortality and cardiovascular events. Next slide. So really for the audience, I'd like to remind everyone that we actually published the Prediabetes ACCG way back in 2017, and we updated it this year to incorporate some of the latest evidence and also, I guess, nuance some of the statements inside the ACG. Feel free to scan the QR code there if you've not seen the latest ACG. I think it brings you to a page where you can download the ACG. So feel free to do so. If everyone has scanned or found the link, you can go on to the panel discussion. So next slide. Sure. So we'll head on to our first topic, and it's really a topic of diagnosis, right? Next. So just to show everyone that really this was a poll result collected from the registration form on really the preferred test for diagnosing prediabetes. So as everyone can see, half of our respondents, nearly half of respondents said oral glucose tolerance test, and about 1/5 said HbA1c. So maybe I would call upon Meng maybe to provide some comments looking at this response.
I think it's a good response, Darren. I mean, people still believe in the OGTT as the standard, right? And in fact, that many patients are, as you actually clearly pointed out, the IGTs are actually the one that are associated with cardiovascular disease, all-cause mortality, and stroke, right? So it's, if we were to actually do fasting plasma glucose or HbA1c, we might not be able to actually pick up, those with impaired glucose tolerance. So we need to be mindful that impaired glucose tolerance is a very specific category, and you can only pick this one up using the oral glucose tolerance test. So I'm actually very happy, that half of the participants actually chose OGTT. Of course, OGTT has nuances, everybody knows, right? It's very leceh, people call it, right? You need to actually fast for at least 8 to 10 hours. You need to go to a specific place, then you take a blood, you drink, a glucose drink, and then you have to wait for 2 hours, then another blood test. So the entire resources put together for a single test is actually, quite heavy compared to a fasting glucose and an HbA1c. I think that's actually a trade-off between these tests.
And I guess I'm fortunate enough to practice in a polyclinic where we actually have the ability to do OGTTs quite easily. And I suspect at least many of our GPs may not have this ability. So maybe, I don't know, I'll call upon Abel maybe to allow him to share some insights then on what is his practice and what is his advice perhaps for our GPs who don't carry the OGTT. Yeah.
So I think as what Jimmy has mentioned earlier, OGTT is the test of choice to diagnose prediabetes, because we not only want to find out those individuals who have impaired fasting glucose, but more importantly, there may be people who have got normal fasting plasma glucose, but they may have IGT. So IGT unfortunately cannot be diagnosed without an OGTT test. So doing an OGTT is still essential. And so I think for most of the GPs, one of the important trends that I have seen over at least the past 10 years is that more and more people are doing health screening. So when you do health screening, of course, most of the standard health screening packages would at least do a fasting plasma glucose as well as a plus minus a HbA1c. So if let's say that the fasting plasma glucose is normal, but the HbA1c is already more than 6%, all right, that actually would make you suspicious whether the individual may actually have pre-diabetes or even diabetes. So such individuals should definitely be followed up with an OGTT test. And I personally think that it is actually possible for GPs to do OGTT because the glucose drinks can be obtained from any of the laboratories which support the GPs, and you can actually store the 75-gram glucose drink in your clinic first, and if there's a patient that needs to do an OGTT, you can then proceed to do the usual fasting test and then get the patient to drink, and then 2 hours later draw the blood for the post-load glucose again. So I don't think it is difficult. Of course, if you're talking about resources-wise, maybe at the start of the clinic, the patient load may not be so high, and in the later part of the day, the patient load may be high, and the GPs may find that it may be practically a little bit difficult for them to do the tests, especially if they don't have anyone to draw the blood and they themselves have to draw the blood from the patient. Then in such cases, you may then want to refer the patient to the polyclinic to do the OGTT, or you can also refer to the hospitals as well. Yeah.
Sure. I wonder whether you have any practical advice, because I guess most of our GPs do run in rather small setups, but yet the patient obviously has to have a 2-hour wait, right? What do you normally advise your patients for these 2 hours? Do they have to sit within the clinic or?
So the important thing about the OGTT is that after they have drank the glucose drink, they are actually not supposed to be so physically active. So they should be sitting down somewhere, and they should also not take additional food, because the 75-gram of glucose is already quite a high carbo load already. So they can either wait in the clinic, or they can wait somewhere else for the second hour blood test.
So I think some of our GPs with their clinics may have some practical considerations for that.
Yeah.
But maybe we'll move on. And I think there were some quite interesting questions that came through at registration. So maybe I'll pose it, and I guess either of you can address it. Why is the criteria for DM diagnosis using HbA1c at 7%, while obviously Americans are at the 6.5% threshold?
Okay, I think I'll just take that. Now, I guess these are all numbers. I think we must always remember. Okay, and 6.5% to diagnose diabetes is really a consensus. There was actually really no what we call, this is not really evidence based. Okay, we must always remember that. Right, so you just imagine that a group of specialists or experts actually they come together and they say, okay, let's actually put HbA1c at 6.5 to diagnose diabetes. Now, for Singapore, we do actually have our own what we call analysis, right? I mean, based on our population health data, and we actually find that fair enough, there might be some ethnic variation in HbA1c, so that makes a single cutoff to diagnose diabetes a little bit more difficult, right? And it's actually well known that HbA1c may differ between any group. Like for example, in the African Black, but their HbA1c level is actually higher than the white, right? So you can actually imagine that if they put a cutoff at 6.5, many of these African Blacks will be unnecessarily labeled as diabetes mellitus, where the normal glucose test like fasting glucose or OGTT may not be diabetic at all. So we need to actually understand all these nuances. So in Singapore, what we actually do is we do the rule in, rule out, what we call policy, right? So we actually choose a HbA1c of 7.0 to actually rule in diabetes. Okay, so we are very sure that if you have a HbA1c of 7.0, you have diabetes until proven otherwise. You don't really actually need a fasting glucose or OGTT to further test whether you have diabetes or not. Whereas if your HbA1c is actually below 7, there is actually a likelihood that your other tests of diabetes, like for example fasting or OGTT, might be normal, right? Or they may actually be in a pre-diabetes state. So that's actually the stand that we actually that we do when we roll out the so-called the HbA1c, the guidance for HbA1c in screening for diabetes mellitus or pre-diabetes.
So moving ahead to a question that's been put up here. So is it possible for patients to get a normal OGTT where the 0 hour is 5.1, second hour 5.2, yet have a HbA1c of 6.1? And in that case, when would you repeat it? Do you repeat it in a year or earlier? So maybe Abel, anyone?
Abel.
Yeah. So like what Meng mentioned earlier, there are population groups in all over the world that have variations in terms of their HbA1c level. So if let's say the individual has got a normal OGTT test, but yet the HbA1c is a little bit on the higher side, we really do need to look at the OGTT results. So if let's say that, as what Darren has mentioned, if it's 5 and 5, then obviously there may be some error with the HbA1c testing, because I mean laboratories are not safe from errors, and sometimes we do get erroneous results from the laboratory. So if the OGTT is normal, then most likely the individual does not have diabetes, and we can just follow up subsequently, either with either repeating the HbA1c, or you can repeat the OGTT as well. Yeah.
Sure. And I'll move on to a question actually from the registration. And this was quite a long question, so I'll just read it out slowly. As we move away from OGTT and towards using A1C for diabetes diagnosis, invariably there are gray zone HbA1c between 6.0% to 7%. And if a patient has a diagnosis of diabetes via OGTT but returns an A1C of 6.3, then this patient is subjected to DRP DFS. But for a patient who only has a HbA1c result and it shows 6.3%, what do we do now? And how do we reconcile this difference in screening for complications? Yeah.
I think this is a very good question, Darren. Okay, that we must always remember that these are all the tests, and all the tests actually they test different aspects of physiology in the body, right? So they don't do they don't actually, they don't test the same thing. Right. So the first question that you actually said is, if the OGTT is actually grossly abnormal, those are actually in the diabetic range, but the A1C is actually, not high. So how do we actually what do we do, right? Now, we must remember that the OGTT is a test of 75 grams of glucose drink. Okay. So we don't drink 75 grams of glucose every day in our life. Not for breakfast, not for lunch, and not for dinner. Especially not for me, but I'm not sure about you all. Okay, I hope it's not in that sense. But we don't actually take 75 grams of glucose. So OGTT is really stressing your body to the limit, right? To actually say, hey, can your body actually handle a 75-gram glucose or not? Right. So if you are not able to handle 75 grams of glucose, and based on a certain cutoff, you are at risk of diabetes mellitus complication, namely retinopathy. That's what we actually worried about. And you are at risk of actually future cardiovascular disease. You are at risk of future chronic kidney disease and everything else related to hyperglycemia. Okay, that is actually something that people must actually understand. All right. But in terms of day-to-day, right, your 2 hours after a meal may be lower than your 75-gram glucose, because again, I want to stress that people don't take 75-gram glucose every day. Okay, so therefore, your mean glucose from day to day may be lower than your OGTT, and that is reflective of your HbA1c. So your HbA1c level may be actually lower, may not be diagnostic of diabetes when your OGTT is. Okay, so that's actually the discrepant between the two tests.
Sure. Got someone who put in a quite interesting question, and I must say, so they say for OGTT, does it matter if someone has a high 1 hour result, get a normal 2-hour result? I mean, I don't normally see this because I guess the reports that we get in polyclinics just only generally have 0 and 2 hours. So I'm not too sure if either of you can address this. Yeah.
I think when we look at most of the guidelines worldwide, the diagnosis of either pre-diabetes or diabetes via OGTT, we only look at the 0 minute as well as the 2-hour mark. Yeah, so I know ever since I came to private practice that there are some labs that actually do the 1 hour reading, but whenever I test patients, I always tell them not to do the 1 hour reading because there is no cutoff that we use for the 1 hour for diagnosis of either pre-diabetes or diabetes. So yeah, it's just 0 minute and 120 minute.
Sure.
Yeah, I agree with that, Darren. I guess that, the 1 minute, the 1 hour sugar may be important in terms of if you want to look at the variability of the sugar in your body, right? But in terms of diagnosis, right, I think, we should actually just follow what the guidelines or what the threshold is, fasting and 2 hours post glucose test.
I've got a couple of questions, and this is an interesting one. What would your management be for a 2-hour OGTT result of 4 millimole or less? And what is the likely cause in this situation?
Yeah. Are you saying that the glucose level is actually lower than the fasting?
Yeah. So I mean, once in a while, and I have seen it myself. And
so what is actually happening in terms of physiology is actually the pancreas is actually over secreting insulin. It's very sensitive to the 75 gram glucose. So simply means, if this person doesn't actually take a meal with enough fibers, right, you will end up feeling hungry all the time, right? So there's actually a risk of him feeling hungry at the end of 2 hours after a meal, and it tends to actually overeat at every 2 hours, and therefore it may actually become more and more obese at the end of the day. Okay, so it's just telling you that, hey, 75, you in your life you can't tolerate 75 gram glucose, right? You can tolerate 75 gram glucose with fiber, something that actually slows down the entry of glucose into the body.
So we got a couple of questions, I think, on this reversal of the diagnosis. So if the FPG screening shows 6.1 to 6.9, repeat OGTT is normal, would you still diagnose patient as prediabetes or IFG, and how would you recommend follow-up?
So, okay, so this probably has implications for a lot of patients nowadays because a lot of people buy insurances. So that makes the diagnosis of pre-diabetes and diabetes even more important to ascertain accurately. So and that is the reason why I would actually strongly encourage all GPs, if the patient has got risk factors for either diabetes or has got screening tests that makes you suspect that they may have either pre-diabetes or diabetes, you should follow up with an OGTT test to confirm. Because if not, and if you label the patient wrongly as having diabetes when the patient actually doesn't have diabetes, only has pre-diabetes, then there may be a lot of implications downstream. So if let's say that the patient has got pre-diabetes diagnosed previously and loses weight, controls the diet, and exercise regularly, and the OGTT becomes normal. So of course we would actually de-diagnose pre-diabetes. You'll be back to normal. Yeah.
Okay.
Yeah.
Okay, so Darren, I can actually just I have two things to actually say.
Sure.
Okay, so first thing first, I think we are actually on this page, I mean the slide. But let me address follow up what Dr. Abel has actually mentioned. Now we must always remember that fasting plasma glucose, fasting glucose and OGTT, they are actually tests, and you must always remember they are actually conditions that you must actually follow when you do the test. Right, you must actually fast 8 hours. It depends on what you eat the night before, whether you have a good night's sleep or not. And when you actually go for the test in the morning, what do you actually do? Do you chase after a bus? Do you take a taxi? And when you actually go, are you in a stressful mindset, or are you actually in a relaxed mindset? Now we must always remember that all these actually affect the performance of the test. Okay, so one day you are so stressful, you go and do your fasting glucose, of course, it's high. One day you're actually so relaxed, you go and do your OGTT, it may be actually normal, right? And of course, what Abel says is correct. And between fasting glucose and actually between the fasting test and the OGTT, if you were to actually do something about it, like you actually go for exercise to lose some weight, your OGT will become normal. In fact, if you fast longer, like for example, if you fast for fasting glucose, you fast for 8 hours. For the OGTT, you fast for 12 hours. Of course, your OGTT will be actually lower. So we must always remember that there are conditions that may actually affect the performance of the test. Okay, so there are people who game the test. So we must always remember that. Okay. Now let's go back to the slide because I think this is actually very important to address. Now, in regards to actually all the difficulty that we actually face from both patients and also GPs, that's what you actually mentioned regarding that we need to actually get people to actually fast. We need people to actually condition themselves before the test. That's where the value of HbA1c becomes important because you don't really need to actually prepare yourself for anything when you go for your HbA1c test, right? As a patient, and for the physician, you don't need to do anything but just take a blood test and actually send home. So there's very little preparation when you actually, when you say that, hey, I want to use a test, convenient enough, I don't have to actually, I can disregard all this, all the conditions that I actually mentioned just now, right? And then I'll just send off the HbA1c. And based on the HbA1c, then actually, I look at what further actions I need to actually take to ascertain whether the patient is normal, whether the patient may have pre-diabetes or the patient already have diabetes mellitus. Okay, so we need to actually understand this also in context of all these tests.
So this is an interesting one. So one of the questions is about some of the patients are already on a keto or low carb diet, and would this affect accuracy of OGTT since they would rarely take sugar on a daily basis?
Fasting will be low, we know that, but the post may not.
So the post should not be affected, right?
Yeah, should not be. Yeah. Unless the patient actually exercise, the patient lose weight, that may actually affect.
Yeah. So what about those who have had gestational diabetes? What is the recommendation in terms of follow-up interval? And is it better to do OGTT on follow-up or the HbA1c?
So for patients with gestational diabetes, we know that 10 years from the time that they have GDM, they are at risk of developing diabetes, and this has been shown in many studies already. So most of the guidelines worldwide would recommend regular testing, but if you actually drill in to look at the details about what they recommend for testing, a lot of the guidelines don't actually spell in great detail what tests to do. So practically speaking, I would like to stress a few things first. So firstly, after the pregnancy where the woman has got gestational diabetes, it is definitely mandatory for the woman postpartum to test, to do a OGTT to confirm whether they have returned to normal glucose tolerance. All right. So because there will be women who may stay pre-diabetic after the pregnancy, and some women do fall through the cracks and they don't go back to see either the gynae or the endocrinologist to do the OGTT. Yeah. So if let's say that the woman after the pregnancy has gone back to normal glucose tolerance, then of course the guidelines is that they will need regular testing. Some of the guidelines specify that you may want to test 1 year after, and then subsequently once every 3 years if the results remain normal. And I think it depends on what the subsequent results show. So the easiest way to test will be to just do a fasting glucose and do a HbA1c as a screening first. And if necessary, if let's say that the fasting glucose is a little bit in the pre-diabetes range, or HbA1c is a little bit higher than 6, then you may want to just confirm with an OGTT whether or not the patient has pre-diabetes or actually has diabetes already.
Sure. So there's another question on follow-up, and will it be necessary for repeat OGTTs on patients who were previously diabetic on OGTT, but now it's very well controlled on diet only with a normal HbA1c?
I'll continue with HbA1c.
Yeah, I think so too, right? I mean, if the HbA1c is clearly within a normal range, I think there isn't a need to put the patient through what is rather painful OGTT. I think there were a couple of questions about OGTT, and in these cases whereby they're worried that drinking the OGTT, being the 75-gram glucose load, can actually precipitate very high sort of 2-hour results. So I was wondering whether you want to comment on that. Yeah.
If you have a very high fasting glucose, you don't really need OGTT. If you are symptomatic for diabetes mellitus, you just need to do a HbA1c or random glucose. So I think we should just follow the guidelines. When we want to diagnose somebody with diabetes, you don't need OGTT for every single patient. OGTT and fasting glucose are only for those with asymptomatic, right?
Yeah. Okay, so I think time is catching on, and I think we've tried to answer most of the questions, and I think we should be getting along with this. So maybe we can go on to the next slide. Yeah, so I think we've got a case study, and I'll just read it out for everyone's sake. Next slide. So this is Mr. K. He's 46 years old, and he works as an IT consultant. In January, he has a BMI of 26, blood pressure of 130/80 on amlodipine, and presents with a fasting plasma glucose of 6.3. And in April, this is his OGTT result, 6.4, and we diagnosed IGT based on a 2-hour value of 9.2, and advise him on appropriate lifestyle measures. And what would be a next step for the patient? So we would actually launch a poll for all our attendees at this point in time. We'll take 30 seconds to do the poll. So just want to read out the options for everyone, and this will probably lead to some discussion. So 1, we can test the HbA1c in 3 months. We can repeat OGTT in 6 months. We can test the FPG at the next annual review as part of his BP sort of annual routine panel testing. Option D, we want to do all 3 tests, FPG, OGTT, and HbA1c in 3 months' time. Or we see him in 3 months to just assess his weight and change in lifestyle before further testing. Yeah. So based on the poll, 42% would see him in 3 months to just assess weight and change. The next highest one with 29% of our participants would test the HbA1c in 3 months' time. And the third highest option was actually do all 3 tests in 3 months' time. Yep. So maybe Abel and Meng, do you want to give some comments on the poll results?
So let's look back at the case study. Can we go back one slide? So this patient, first of all, was found to have what seems to be an impaired fasting glucose level in January. So when OGTT was done in April, it confirmed that the patient has got prediabetes with both IFG as well as IGT. All right. So usually for such a patient, of course, we would advise lifestyle measures, which we will touch on in the next section of this talk. And the repeat testing, unfortunately, is not going to be standardized. So it really depends on what is available. It depends on who is following up the patient. And so I just want to talk about things in general first, at least from the GP's perspective. So number one, I don't usually repeat OGTT for patients diagnosed with prediabetes that soon. Yeah, because first of all, OGTT is a very laborious test, and the 75 gram of glucose, I can tell you, is actually quite disgusting to drink because it's very, very sweet. Yeah, so even I have heard of women who in pregnancy, when they drink the OGTT drink, they actually vomited out because it's so sweet. All right, so I usually would at least only repeat the OGTT at least 1 year down the road. So which means that, can we go to the next slide please? Here. Which means that the options of repeating OGTT at 6 months or repeating all the tests in 3 months, I probably wouldn't do all that. So what I would usually do is I would actually just monitor either the glucose and the HbA1c. So I know monitoring the HbA1c is not a standard test for diagnosis of pre-diabetes, but if there is improvement in the HbA1c level that and of course collaborated with the improvement in the blood glucose level, then we know that the patient's lifestyle measures are actually working to help them improve their glycemia. All right. So where glucose is concerned, I usually would ask them to do a random glucose. I will ask them to actually come close to 2 hours after their meal, whether it's breakfast or lunch, then come and do the testing, and that would actually help me assess whether or not there's some improvement. Although we know that what the patient eats may not even reach 75 grams, but at least it gives me some idea what the patient's improvement is. But more importantly, of course, the other measures that we take, like the assessing the weight of the patient, is going to be very important as well.
Sure. Okay, so I think that probably segues quite nicely into our next section on lifestyle intervention. Maybe when we move to that slide, yep, and the next slide. So maybe perhaps, just to showcase to everyone, then on the current ACG, there are some patient education aids that are available. I think it's somewhat well summarized of what to advise patients. And I think another source of information will obviously be the Health Promotion Board portal. And I think there are patient information as well as tools that are readily online for things like recipes and meal plannings and all. But maybe just to kickstart this, maybe I just want to ask our panelists, what do they normally advise patients on a practical basis, right, in a short consult session in our clinics when you have diagnosed someone with prediabetes? So maybe Abel, you want to start off first?
So for patients diagnosed with prediabetes, definitely the first management will be lifestyle intervention, which means diet control as well as increasing exercise, especially for those who never exercise, to try to get their weight down. So a lot of people who have prediabetes are overweight or obese. All right, so that's the truth. So we need them to reduce. So in terms of diet, I try to get them to understand what are the common foods that contains carbohydrates from our diet, so that I would ask them to reduce the consumption of such foods. And for many people who don't exercise, and in fact, a lot of people don't exercise, so I would usually get them to increase physical activity gradually, because it is not practical to get someone who has never exercised for years to suddenly exercise 3 or 4 times a week or even 5 times a week. It is going to be, well, I mean, some of the patients may be able to do it, but I can assure you that in the long term, they are just going to give up, because it's going to be very, very tough in the setting of very hectic work schedule, or even their family life and things like that. So I usually get them to start at least once a week of exercise first. Easiest exercise to do will be brisk walking, and gradually over time I would increase the frequency of exercise to at least 3 times a week. Yeah.
Meng, anything to add? What is your normal practice when it comes to advising patients?
Yeah. I mean the question is always that that usually I do is I usually ask them how they feel about it, right? I mean the sugar test, and what are their worries, their concerns, and also whether they felt that this is a doomsday diagnosis, or whether that they don't care, or maybe that all the family they have diabetes anyway, so they actually say, oh, okay, it's part of the family, and something like that. So after knowing that, then I will try to actually ask, do you think that that you are able to actually change it? And if you are able to change it, then what do you think that at this current state that you are able to do to change the glucose abnormalities? So that's what I'll do. And now I'll try to tailor right? According to the diet, the physical activity, as what Abel actually mentioned, there are people who can change in terms of dietary patterns. There are people who can't change, that can change in terms of physical activities. In some people, we just need to break the sedentary lifestyle, as simple as that, right? And in some people, it's just, you just need to actually do some behavior cognitive training, right? And that may actually help them in terms of actually come up with motivation to change, right? So I'm not so prescriptive in terms of what I tell them. I mean, there are actually a lot of guides out there, but I will just tell them that these are the things that you can actually do or look it up. I'm actually more than happy to or open to, if you have any questions, or if there's something that you're actually interested in, we can actually discuss it further, how it may actually help you in your condition. I patient will actually come and ask me about intermittent fasting, right? Then we actually talk about 4-3-5-2, 12-8, 12-12, whatever, then we have open communication, and as they become more curious and they actually think that they are able to do that, then they will be able to sustain the behavior and also the effort, right? But what is actually really important, right? At the end of the day, it's not about reversing pre-diabetes. Okay, I need to actually stress on that, right? It's all about what is actually the intention of the patient, right? Are they afraid of diabetes? Are they afraid of amputation? Are they afraid of heart disease? Are they afraid of stroke? Or do they want to actually do something that they can't do because of pre-diabetes, like for example, buying insurance? I think we need to address a bigger goal rather than reversing pre-diabetes.
Yeah. So I agree on the points. I think a lot of times, at a very sort of a nascent stage, obviously they have no symptoms. Just to get patients to understand really the condition itself is quite a challenge. I spend quite a fair bit of my time trying to explain even this spectrum, right, of normal glycemia to diabetes and what it means now to have pre-diabetes. And I guess my own practice tends to also, I try to individualize the advice based on their existing lifestyle as well. So obviously someone who's completely sedentary, then where are the minimal increases that we can go to? And then sometimes I find that, there are opportunities. So I used to advise my patients like simple things that can be repetitively done, like stop one bus stop earlier to get more walking on, and stopping, just one floor earlier to walk some staircases, just to get some activity in is usually what I advise. So I also don't normally follow, I think, if I tell patients 150 minutes a week, it sort of just falls flat, right? They don't know where to begin. But maybe I'll just take some of the questions, and I guess some of it we have answered. There's one interesting one. I don't know what your opinion is. What's a good diet modification to allow satiety to prevent rebound binge eating? Any of you have an opinion on that?
Binge eating is a psychological diagnosis. You need a psychologist for that. I mean, if a patient has rebound binge eating, we need to actually really understand, right? Why does a patient actually has binge eating in the first place? I mean, many people, okay, one is actually could be genetic. That's why they binge eating. There is actually a condition known as actually Preservability, right? They just eat non-stop, right? They can't stop because of actually some genetic disorder. But people who actually binge eating, usually they have underlying psychological issues, right? And we really need to address those psychological issues. You might actually need a psychologist to actually help, right, in this context. Because unless you actually address the psychological issues, I mean, the dietary or the lifestyle advice is not going to work in these people. And these are the ones that we normally don't even send for bariatric surgery. Because at the end, after bariatric surgery, they tend to be suicidal.
We've got a question here about how much time would you recommend that the GP spend advising his patients on lifestyle modifications, graduated exercise, weight management? Is there a standard package that would be useful? So I think the standard package is probably found on that one-page summary. I mean, in terms of the content, but I think it's about how you explain that content that makes it really individualized and meaningful, and whether the patient can apply it. I'm not too sure whether either of you have an idea of what's the time that you probably need.
Particularly, sorry, I think practically speaking, it depends on which GP it is, it depends on the practice, it depends on how busy, how much time you have to spend with the patient. But the important thing that I want to stress is that it doesn't have to be everything you have to tell the patient during the first visit. Yeah, you can just address perhaps just two issues, one for diet and one for exercise. Just tell them to start exercising if they haven't been exercising for a long time. So like I said earlier, just get them to exercise once a week for at least 1 to 2 months first. Diet wise, you can just pinpoint something from the patient. For example, you can ask the patient like, where do you usually eat? Do you usually eat outside or do you eat at home? Someone cooks for you. So obviously, if for people who usually eat out, you need to give them certain pointers to help them to try to reduce their carb intake. So I will tell them that you can still eat rice, you can still eat noodles, but you have to reduce the portion size. So if you reduce the portion size, you will need to increase the protein that you're eating, because otherwise you're going to feel hungry quite soon after, and you'll be craving for food again. Yeah. And then at the subsequent visit, when the patient comes back, you can target another area to sort of zoom into. You really don't need to spend like half an hour just talking to the patient about everything about diet and exercise.
Yeah. So I think it's important to realize that a lot of us obviously would have the ability to have repeated reviews with the patient.
Yeah.
So sort of segment the knowledge, don't download it all at once. And then probably even good to check
Darren,
back.
Darren, I think I need to interject, because I think there's actually something very important. And this is all about, engagement, right? We need to get patient into the treatment process. All right. We cannot be the one who actually tell patient, this is what you need to do. Right. We need to actually, ask patient, hey, what would you like to do? Okay, and then we try to actually help the patient. I mean, the patient must come into the process. Otherwise, if we start telling patient, hey, okay, let's work on the weight today, the patient may not actually come back the next time, because that's not what the patient wants to do in the first place. So it's actually very, very important when it comes to actually chronic disease, or we want patient to come back, because we believe that frequent touch point change behavior. We need patient to be the one who initiate what they want to do. Okay, we can tell the patient, hey, there are 3 things that we can actually do, like diet, physical activities, or certain things like cognitive therapy. Is there something in your mind that you think that we can actually discuss today? As simple as that, right? And then the patient say, okay, why don't we talk about diet? Because I think that I can change a little bit about that. Okay, then you can actually start, by actually saying, okay, why don't you actually let me tell me first? What do you eat for breakfast, lunch, and dinner, and in between? So then the conversation continues, and then then immediately open up, to a different dimension in terms of counseling.
Yeah, I think a lot of motivational interviewing and guiding patients through a stage of change, right, really is important through this process.
So we need to actually understand what patient really want to change at the point in time.
Okay, so I think time is catching on, and I just want to get back to the case study. So maybe if we can move to that slide. Yeah, next slide. So Mr. K has come back, right? And after we've explained to him that he has IGT and advised on the appropriate lifestyle measures, and then we now see him in November 2021. His weight and BMI are unchanged, and his HbA1c is 6.4%. So same patient, it's now 11 months since we first found the FPG of 6.3. Diagnosed IGT since April, and now in November, HbA1c of 6.4. Can we move on to the next slide? So there's some options of management, and we'll launch into another poll of our audience. So how will you proceed with Mr. K at this visit? A, just monitor. B, intensify lifestyle intervention. C, initiate metformin. D, initiate glucose-lowering medication other than metformin, whatever you want. E, refer him to a dermatologist. So maybe we can start the poll now. Okay, so we have top result, intensify lifestyle intervention. 45% of respondents, and 40% of respondents said initiate metformin. Just Monitor was the third one, just ahead of Refer to Diabetologist, and very few will initiate any other medication outside of metformin, just 2%. So I guess that brings us nicely into the section on pharmacotherapy, right? Maybe I'll just ask either Chin Meng or Abel to respond to this poll first of what you think. Yeah.
If you ask me, I would just say it's a question of actually how do you approach a patient at this point in time. Seriously speaking, I mean, the first time we saw the patient was actually in January, and now it's nearly the end of the year, right? And if you look at the glucose test, I don't think the glucose test actually changed at all. The fasting glucose is actually very stable between January and April, and the A1C is actually 6.4. I think it's actually appropriate for the level of fasting glucose in the 2 hours post. So I believe that the level of actually, glucose abnormalities has not changed over the past 11 to 12 months. And also that the weight hasn't changed as well. To me, I will congratulate the patient. I look at the positive side. I will actually just say that, well done. Okay, I mean, a lot of people will actually have gained weight, but you didn't actually gain weight. At least, you actually maintain your weight. Of course, if you can actually lose weight, that will be actually better. But, at this moment in time, I think that you did very well. You didn't actually gain weight, and that your sugar didn't actually get worse with that. But what is actually really important is actually, this patient has metabolic syndrome. So as part of actually the screening process for metabolic syndrome, I will actually screen for other cardiovascular risk factors. Now, I will actually ask a patient, is a patient comfortable with HbA1c of 6.4? Right? You will be able to actually tell me whether it's actually worried, not worried, and if it's worried of what, right? And that can actually address, those concerns that of like whether he actually needs the medication or not. But I will not be prescriptive at this point in time. I will actually just ask the patient. I will actually congratulate. He'll be more positive towards him, and then ask him for his concern, and then we can re-establish new goals for the
So
following
maybe
year.
following up to that, and this was from some questions on the pre-reg. At what HbA1c reading would you recommend one to start treatment, right? And really, like, at what level of HbA1c would you start to recommend oral drugs like metformin for prediabetes? Yeah. Maybe Abel.
So I'm going to talk about both HbA1c and the oral glucose tolerance test results. So obviously, there's no guidelines anywhere worldwide which will tell you whether what kind of numbers you should follow to start pharmacotherapy. But we know that prediabetes is a spectrum. It's a spectrum that there's at one end it is closer to normal glucose levels, and the other end it is closer to diabetes. So if let's say that either the glucose tolerance is actually closer to the diabetes mark right at the start when the patient is diagnosed, I would already have started pharmacotherapy together with lifestyle intervention. So for this patient, of course, 9.2 is somewhere in the middle of the impaired glucose tolerance range, and I would certainly not have started at the start, and I would have instituted lifestyle measures, and of course the subsequent testing showed that his HbA1c is 6.4%. So for myself, I would usually start pharmacotherapy. If let's say that I'm monitoring via HbA1c, I would actually start if the HbA1c is more than 6.3%. Yeah, because that actually would mean that the patient is going to be either in the middle of the impaired glucose tolerance range or closer to the diabetes range, actually. All right.
One of our attendees really want to. Oh, yep. Jimin, go ahead.
Darren, I think it's actually very important for us to actually mention that, again, number is number. Okay, we don't want to play number game. All right, so we need to actually inform the audience that, HbA1c, fasting glucose, OGTT, these are all number game, right? So the numbers must actually plus with something meaningful before you actually start treatment. So in clinical trials, like for example, DPP, right? I mean, the diabetes prevention program, they already have identified, in what category, that metformin would be actually most useful. So these are the people, with very high risk of diabetes. That means, IGT plus IFG, and they are obese. So it simply means BMI more than 30, right? and if they have a history of GDM, right? So we know that the progression to actually diabetes is actually very high. Okay, or they have actually more severe fasting, more higher fasting glucose, like for example, it's actually like in the range of nearly becoming diabetes, like for example, fasting glucose of 6.6, 6.8, or 6.9 instead of 6.1, right? Then these are the categories of patients that you say, hey, HbA1c 6.4, HbA1c of 6.7, I will actually start metformin because they are really at high risk of progression to diabetes. Okay, but beyond that, if a patient only has an HbA1c level of 6.5 and there's no other, whatever that I actually mentioned earlier, I won't start the patient on metformin, seriously speaking. We actually understand that the actionable HbA1c is 7.0 and above. That's why we actually say that the HbA1c for diagnosis of diabetes is 7.0 because 7.0 is an actionable number, right? So if you have an HbA1c of 7.2, 7.3, simply means you need to do something, right? Otherwise, the patient is at high risk of complication of diabetes, right? So the risks and benefits of actually treatment to the disease complication, is appropriate. Otherwise, the patient may actually have harm from the treatment that you actually render the patient.
I agree. So I think one of the points is really also, at this stage of the condition, the patient is asymptomatic, right, completely. Yet you potentially will be giving a drug and that may even give rise to, the usual gastrointestinal side effects and all. So I don't know whether you have any practical advice on that sort of counseling when you want to start patients on metformin in such a situation that you want to share with our participants.
I think the starting of metformin should be quite universal. We actually start slow, go slow. I mean, start low, go slow. I think probably that's what it is. I mean, you start with 250 BD, then you actually increase to 500 BD, and then thereafter 850 BD. And that is actually the dose that, what the DPP or diabetes prevention program actually use in the prevention of diabetes mellitus. Okay.
Yeah.
Of course, I mean, the problem with metformin is, you need to ensure that the renal panel is actually normal, right? And actually, and this patient is hypertension. So anyway, you're going to actually measure the renal panel once a year. 5 years, down the road, you need to actually ensure that the vitamin B12 is actually normal as well. I believe that the audience today will actually know that, metformin has a strong association with vitamin B12 deficiency. And that's usually, related to the duration of treatment. So at the end of 3 to 5 years, you have to actually measure at least, once, right, the B12 levels.
There's a question here which is quite interesting. Is there a likelihood of complications going to be higher for a long-term pre-diabetic patient, like more than 5 years, as compared to a pre-diabetic patient who's under pharmacotherapy with a very healthy HbA1c level?
The important thing to note is that there are studies that have shown that people with pre-diabetes, a very, very small minority, may already have diabetes-related complications already. And why this is the case, it may be because, it could be because the patient may have actually have diabetes already. It was undiagnosed, and then subsequently, for whatever reason, maybe weight loss, improved lifestyle measures, has gone back to the pre-diabetes stage. Yeah, so it is important to then try to make sure that whatever treatment that we are instituting for the patient, whether lifestyle or pharmacotherapy, is helping the patient. So of course we will we will look at the patient's weight, we will look at the numbers from the test, because that's the only objective things that we can look at. So to tell us whether the patient is improving. So one thing that I want to mention is that I always tell my patients that starting medication is not it's not like when we start the medication, we will never stop the medication. So it is always dynamic. So the lifestyle changes are also dynamic. You can improve in lifestyle changes. You can also fall back to your old ways again. So if let's say that the patient starts metformin and also works very hard to lose weight, to exercise, to control their diet, and things improve, I will tell the patient, okay, we can try stopping the metformin. So I always assure patients that it is not starting and then they are on the medication for the rest of their life, because that's what a lot of patients don't really want to hear about. Yeah, and I think just a note about pharmacotherapy. I think at the moment only metformin has been shown to be effective in at least reducing the incidences of diabetes in people with pre-diabetes. Of course, lifestyle changes in the DPP study works better than metformin. So there have been smaller studies which show that acarbose may be helpful as well. But of course, I think nowadays most of us don't really use a lot of acarbose, plus the fact that acarbose also has GI side effects as well. So and we must also understand that apart from the GI side effects of metformin, metformin has been used for a very, very long time now, and we know that it's generally very safe, especially if you start at low doses and work our way up. The patient most of the time wouldn't get much side effects at all.
In your experience, are there differences with brands of metformin? There was a question related to that.
So of course, in terms of the GI side effects, studies have shown that the extended release metformin may actually give less GI side effects compared to the normal generic metformin. But of course, if let's say that the GP doesn't stock extended release metformin, you can still use a low dose generic metformin as a start, like 250 BD first. Yeah.
I usually advise my patients to really try it for a good 2 weeks first, because they may get some of it in the first couple of days. Yeah. And then there seems to be some, tolerance that comes in after that. It tends to settle. So I think for GP colleagues, that would be useful advice to pass on to patients. And I think really the other question is really, do you have any comments about the role of other glucose-lowering medications in prediabetes? And I guess we can't escape the newer agents that come onto the market now. We'll comment on that, whether it's a SGLT2 or GLP-1s, really. Yeah. Either of you.
Okay, as what Abel actually mentioned, all the treatment for pre-diabetes are actually really, consensus, right? So this is actually no evidence base except for metformin, probably, in the DPP, and acarbose actually in another study. Now, in a lot of other, these like these thiazolidinediones, in the past, rosiglitazones and pioglitazones, they have been actually tested in pre-diabetes as well. But yes, we actually understand that they are associated with a lot of side effects, right? Other than that, when you talk about DPP-4 inhibitors, the GLP-1, the receptor agonists, and also the SGLT2 inhibitors, so these are the new agents. I don't think there's actually any evidence that we say that they are useful in people with pre-diabetes. If you were to actually use, it would be actually off-label.
Yeah.
So simply means, it's all about consenting, patient understand, and then, as long that, that between you and your patient, you understand the risk and benefit, and the patient is actually, able to appreciate and appraise, and then, that's actually off-label use. But for us, we don't.
Yeah. There's a question here about, some consistent intermittent fasting has been mentioned in the US, and that shows that some people can actually sort of reverse diabetes and not use medication. And I guess, the question is really, have we seen anything like this in Singapore in your experience? Yeah.
I think what is actually important is the weight loss and not really, the way of fasting, right? Because you actually understand that Ramadan is also a form of intermittent fasting as well, and people don't get reversal of diabetes during Ramadan, and in fact, the diabetes actually get worse during Ramadan, or might actually get worse during Ramadan. Now, we must remember that there are a lot of studies out there already, okay? And I think there are actually something like maybe 4 or 5, studies on VLCDs. VLCDs is actually very low calorie diet. And these are the people that take, their calories actually like below 1,000 kilocalories per day, right? And they do this for the first 6 months for those with actually treatment naive, newly diagnosed diabetes. At the end of 6 months, many of them, they lose about 15 to 20 kilograms, right? And the diabetes, the number of people who actually get reversal of diabetes is 80 to 90%. So reversal of diabetes, if you can reverse diabetes, you can reverse pre-diabetes, okay? So if you really want to reverse diabetes, it takes a huge commitment, right? A huge commitment, and actually the patient is able to sustain it, right? To actually lose the weight at least 10 to 20 kilograms, right? And you actually really see a reversal of diabetes. That's the reason why bariatric surgery is so powerful when it comes to reversal of diabetes mellitus. It's all because of weight loss. And the weight loss is not about 3 kilograms or 5 kilograms. We are talking in the quantums of actually 10 to 20 kilograms in that individual.
So I'm wondering whether either of you have ever sort of tried to apply, I guess what Meng was referring to was, I think, Sir Roy Taylor's work, right, on this very VLCD, and I think he advocates a very sort of high amount of weight loss, and I think there's some theories about everyone has this individual threshold, right, of weight that can be gained before we tip to diabetes. I was wondering whether practically have you ever applied it to any patient here in Singapore?
Yes, I mean, I remember I have a patient with 23, I mean BMI. Of course, he has hypertension, and he came in with pre-diabetes, seriously speaking, I'm not kidding, right? And actually tell him that, hey, you need to lose weight. And he actually lost weight, and the BMI, when he came to see me like 4 months later, the BMI actually went down to 21 point something, right? And this is a male. Okay, so an Asian male, beginning with a BMI of 23.5, pre-diabetes. Right, and when it brings down the weight to 21 point something, the fasting glucose actually normalizes. So it went down to actually 5 point something. And to me, a bit of weight loss for that person actually changed the glycemic status. For my patient with diabetes, I put many of them on meal replacement. I mean, very few on VLCDs, because VLCD, as I mentioned, is a big commitment. But many of them actually on 1 or 2 meal replacement. They lose 5 to 10 kilograms of their body weight, and you actually see that A1C actually move at least 1 to 2%, right? And that's a reduction in actually the diabetes medication as well. So the weight loss is actually very, very important in terms of how we manage chronic disease. There's very strong relationship with obesity or excess of fat.
Abel, I don't know, in your experience, anything?
So I've also have patients who most of the cases that I've seen a lot of weight loss are actually in patients who are diagnosed with diabetes. So they are obese or even morbidly obese, and they are diagnosed with diabetes, but they know that they don't want to develop all the complications of diabetes subsequently, and they really want to do something about it to improve their glycemia. So many of them would actually go on very, very strict diet. They will start exercising, and I have one recent patient that lost 20 kilograms of weight just from their lifestyle changes. Of course, when the patient was first diagnosed, I did start diabetes medication, but the diabetes medication just keeps dropping in dosage as the patient improves, and now the patient is just on metformin alone. So definitely weight loss will be very important for many of the patients. But I just want to address maybe just one of the questions which I've seen earlier about patients who are normal weight but has been diagnosed with pre-diabetes. So we know that in Asia there are people who may have beta cell dysfunction that is not related to being overweight. And such patients, of course, if they are found to have pre-diabetes, lifestyle changes, diet and exercise will still be important, to help to improve. So lifestyle changes, exercise is important, not to help them to lose weight, but to help them to at least improve a little bit of insulin sensitivity, and as well as to help them to control the postprandial blood sugar level. So it will still be important, certainly for such patients. Yeah.
Sure. Okay. So maybe it segues nicely to us about the follow-up. And I think one of the questions that is recurring and really is about the diagnosis and removing the diagnosis if a patient improves, right? So you've got a patient who you've done OGTT that shows pre-diabetes and IGT even, but maybe with really good lifestyle measures, a repeated OGTT is completely normal. What is your advice for this situation? Yeah.
Okay. So for people with diabetes mellitus, right? Even after bariatric surgery, I mean the glucose actually normalized. We don't actually call them cure, we call them remission, because we believe that if they go back to their old ways of actually overeating and they become obese again, the diabetes will actually come back. So simply means on the risk level, they're actually at higher risk than normal people of getting diabetes, right? And people don't get younger, like, people get older. Right? As you get older, your beta cell is actually worsen, in terms of performance, and you actually get more insulin sensitivity because your muscle actually it becomes sarcopenic. Basically, you lose muscle, right, as you become older. And those compounding factors actually increase the risk of diabetes, as you become older. In fact, when in our own national census, we know that if you're 65 years old and above, at least 1/3 to 1/2 of the population have diabetes mellitus or pre-diabetes. You can't run away from that diagnosis. What you actually do today, the endowment that you put in today, actually delay your diabetes, for many, many years down the road. So for example, if you don't do anything, you get diabetes over the next 5 years, right? If let's say, for example, as young as I am, 30 years old, right? If I don't do anything, I get diabetes at 35, right? I will get complication of diabetes, right? For example, dialysis, for example, amputation, stroke, heart disease within the 20 years of diagnosis. And by then, I'm only 55. I should be productive. I should be able to actually do all the things I want to do. But at the age of 55, because I get diagnosis of diabetes at the age of 35, I get all the complications of diabetes. But just imagine if I were to actually do all that I could, right, to reverse my pre-diabetes today, the endowment of my insurance I put in today, and I'm able to delay my diagnosis of diabetes all the way to age 55. I will actually get, complication of diabetes when I reach 75 to 80. By then, I will have gone already. I may have already gone in place before I get a complication of diabetes. So that's actually the important thing. We cannot lose sight of the future, right? So I think in terms of chronic disease management, right? At this moment in time, many people they are looking at short term. They don't look at actually the long term. But in chronic disease management, what is actually very important is actually the long term, right? I mean, of course, short and long terms are important, but the goal is always the long-term goal. So again, short answer, Darren, there's no such thing as cure.
Yeah. Yeah. So I think, just for even for the participants, I think if they just type diabetes care, diabetes remission, I think you might even find an article, right? And I think there was an article in diabetes care that even staged, right, whether it's full remission or something like that in that article.
Full remission, partial remission, depends on
Yeah,
the
partial remission or full remission. Quite long ago, actually, that one. But maybe just to ask Abel and some of our questions also really about what is your sort of practice in terms of follow-up of patients for people with pre-diabetes, sort of how frequent and what sort of testing modality do you normally use?
So as someone I've mentioned earlier, I would usually, follow-up testing, I would usually test HbA1c and a random glucose, and I would tell them to eat 2 hours before doing the random glucose. So I would repeat an OGTT only 1 year down the road after their last OGTT. So I don't subject them to OGTT shorter than a year. All right. And what's the other part of the question?
Oops. Sorry, can we go back to the question? Sort of how frequent and what tests? Yeah.
Yeah, so for follow-up, I usually see them depending on the level, I will see them every 4 to 6 monthly. Actually, and of course, at the start, I may see them 2 or 3 months, but then subsequently, I would see them 4 to 6 monthly, unless there are certain risk factors, like for example, if they have high lipids, or if their weight don't improve, yeah.
Yeah. I think many of our patients with pre-diabetes, they often have coexisting, hypertension, lipids, and all. So I guess for my practice, a lot of them are already sort of an annual follow-up for those conditions where they get a fasting plasma glucose. So I generally don't add the OGTT even on an annual basis, and I just use the fasting plasma glucose, because if it returns normal, then at least the patient sort of avoids the 75 gram glucose load for that year. Yeah, so I mean that's just my practice. I think there's another interesting questions about what do we then do for patients who have been put on metformin, and we want to comment on the need for a washout period when you reevaluate the prediabetes status.
Okay, so there's actually two things that you are asking here, Darren. So if you are just, following up the patient, with HbA1c, you don't really need to wash out. If you are following up with actually fasting glucose or OGTT, you need to actually stop the metformin before the test. But if you really want to actually re-diagnose, right, whether the patient has pre-diabetes or not, then you need a washout. Because you understand that diabetes is actually, whether the diabetes is used to delay or to actually to mask, right, the diagnosis of actually of diabetes mellitus. So you really need to actually wash out. And the washout period is about 1 to 2 weeks. It really depends on what your intention is.
Yeah. There were also some questions and I guess related to the concomitant conditions like lipids and all. So one is what would you recommend, I guess, in terms of lipid targets for someone with prediabetes and perhaps IGT or RFG? Is there a difference? And I guess another one is also really, is there a risk that statins itself contributes to prediabetes? I guess especially there was some news a long time ago about rosuvastatin from, I guess, Jupiter, right? If I'm not wrong. So I don't know, maybe either of you can comment on that.
So for my patients with prediabetes, of course, I treat them as if they are at risk of cardiovascular disease as well. Yeah, because prediabetes, there are studies that show that the long term there's a slightly increased risk of cardiovascular disease for such patients. So in terms of LDL target, I would actually set their LDL target the same as someone who has diabetes. So I would target for either 2.6 millimoles or 100 milligrams per deciliter. Yeah, so to reduce their long-term risk of developing cardiovascular disease.
Maybe Chin-Meng, you want to comment about the risk of statins?
I would not actually dismiss the concern. All right, I will actually, if I were to speak to the patient, say I actually share your concern as well. Right, but let's appraise, the risk of you getting a heart disease or stroke. Right, and there are many ways of us actually doing that. Like, I think if you look at, we do actually have our national guidelines in terms of how we actually calculate, the risk of a patient getting a heart attack or stroke over the next 10 years. And if we can actually do that together with the patient, and the patient actually understand, whether the risk is high or low. If the risk is high, right, I mean, you want to start setting and the patient is still not convinced, you can always say, would you like to actually do further testing to actually see whether are you really at risk of a heart attack or not? And that is something that you can do, like, for example, treadmill test, a stress test, or calcium scoring. So something to actually just tell the patient, are you at really high risk? And then, then the risk of actually this statin causing diabetes becomes minimal, right? Because, getting diabetes, you don't actually get into trouble, for the next 15 to 20 years. But if you get a heart attack, you may actually just die suddenly. I think that's actually the most key important message here. But I will not actually dismiss, the concern.
So just following on to your comments, I think what you suggested, like a lot of the stress testing, calcium scoring, they may not be that readily available to a lot of our GP colleagues. You recommend any other thing, like maybe, I don't know, HSCRP? Would that be useful?
You can do that. Yeah. Many of them will be actually elevated because, if you actually look at the people with IGT, hypertension, obesity, the HSCRP will be actually high anyway.
Yeah.
Right. Yeah. So they'll be high. I mean, there's some inflammation, and if they smoke, you should actually get them to actually stop smoking. Right. If they actually obese, you should get them to actually lose weight. And maybe this is actually as simple as it is. You may already reduce the risk of cardiovascular disease rather than actually starting the statin.
Yeah.
And there are actually people very comfortable at actually the natural way of reducing cholesterol. If you actually were to tell them, hey, if you actually take more oats, for example, more fibers, right? And they are actually what we call natural statins. They can actually sterostatin. They can actually buy from the off shelf, and this actually potentially can reduce your cholesterol level in the body as well. So I guess, dietary modification, lifestyle, and some of these, like, may actually reduce LDL per se, if they're actually worried about, statin-induced diabetes mellitus.
Yeah. And I guess really we talk about, LDL. So I guess even for blood pressure, right, you would also sort of impose the targets as for with diabetes patients. So I guess locally 140/80 minimally, right? And maybe just to take this on a bit further, would you then have different targets for people with IFG versus IGT?
I personally don't differ the targets, yeah, for simplicity reasons. Yeah.
Okay. Yourself, Chinmay? I don't know.
No, I don't actually. I'll just look at the BP as the BP itself.
Okay, sure. Yeah. So I think someone put down here whether on the reversibility, right? So maybe whether we should stress that point again, and participant wrote, so it has a patient with IFG with a FBG of 6.1 from OGTT many years ago, but the OGTT is now back to normal readings, right? And in fact, fasting blood glucose is very normal, 5.0 to 5.5. So can I then explain to the patient that he has no more IFG and just plan for annual follow-up with fasting blood glucose? So I think that would be perfectly reasonable, right? Especially if you already have a FBG that's really 5.0, 5.5 is really normal. So I don't think there's any need to do a OGTT for sure. I guess it's really about the label, right? And in this case, when it's really so mild, what would you recommend for the diagnosis label?
So I mean, the thing is actually that's actually normal lah. Basically,
Yeah.
you just congratulate the patient. You actually you managed to reverse your conditions, or at least as for now, and this is really your effort. And it's not me, the doctors, but it's actually really you. And as long as you maintain what you are doing, you actually most likely your condition will not deteriorate over the next few years lah. So, and you just can be assured that we will retest the year after, on OGTT to actually see what's your glucose level thereafter. I think the thing is, what is important, in our practice is actually to pick up the positive things, right, and actually reinforce the positive things, right. Back to the patient, right, so that the patient actually take it as a motivation to stay in that positive manner.
So there's a statin question again, and in your experience, have you ever seen really clearly that statin is the one that's causing the high fasting glucose level?
Mm.
No, right? Yeah, I
I
think
mean,
practically we can never see very clearly that it's linked just to the initiation of statin, right? Yeah.
yeah, that's right.
There's one question here, I guess from ophthalmologist, that we sometimes ask for the HbA1c to be reduced gradually, and I guess this is already treating a diabetic patient to reduce the risk of exacerbating diabetic eye complications. But we don't hear back from endocrinologists about the practicality of such requests. So is the titration of HbA1c reduction practical or medically acceptable? I guess in slowing down the rate of reduction. Yeah.
People with actually very high risk eye complications, such as, for example, the macular edema, the proliferative eye disease. It is actually true that if there's actually a sudden reduction in the HbA1c, they actually get worsening of the eye condition. We know that. Okay, we know that from actually the DCCT as well, right? Where there's actually a rapid reduction in the HbA1c with insulin therapy, right? You actually get a deterioration in the vision, right? So it's actually true. Right, so we will not dismiss this. So in those with proliferative eye disease, where there's a lot of bleeding, where they're still planning for laser therapy, in macular eye disease, macular edema, we tend to be a bit more gentle in actually our glucose reduction. Right. So the titration process, we won't be so intensive. Even if we give insulin, we will actually gradually bring down the HbA1c over time, rather than trying to normalize the glucose over the next 3 to 6 months.
Yeah, I think there's been similar evidence for a lot of neuritis issues that if you drop the A1C too aggressively, they tend to get sort of neuritis, neuralgias, and all as well. Yeah.
There you
So maybe
go.
just one last question. So for a person to join late, and just as a follow-up, really, do we need to send pre-diabetes patients for annual retinal foot screening? So he's shaking his head. So I think even though there's a very, very small chance of it happening in these patients, we don't recommend, right, annual eye or foot screening for patients with pre-diabetes at this moment. Yeah.
I think we need to actually stress the diagnosis of diabetes mellitus, right? The fasting glucose of 7, the OGTT of 11.1, and the HbA1c of 7.0 or 6.5. Now, these are actually the level that actually tells you, hey, this patient is at higher risk of moderate diabetic retinopathy. Okay, so that's actually how we actually, get our threshold for diagnosis of diabetes mellitus. We actually say that, the complication that is actually meaningful to the patient is moderate diabetic retinopathy. Okay, so the diagnosis of diabetes is based on the eye complication, not on anything else.
Okay, so I think time is catching on, and maybe
Can
we'll.
Abel,
Darren,
can I just touch on one last point? Okay.
Sure. Yes.
Yeah, because I saw the question here about continuous glucose monitoring. So I just want to touch on the use of continuous glucose monitoring in people with pre-diabetes. So obviously, continuous glucose monitoring is not really indicated for people with pre-diabetes. I would not encourage patients to use such devices, but if they want to use it and they want to use it to see how their dietary changes is improving their glycemia, I certainly wouldn't stop them. Yeah.
Yeah. I mean, I think sometimes they would find it somewhat educational if they can interpret properly, but there are probably still a lot of nuances around a lot of the CGMS device. I don't find it all that accurate sometimes.
Yeah,
so,
that's right.
Okay, so maybe we'll move on to our summary slide because time is catching on. So I want to firstly thank Dr. Khoo Meng and Dr. Abel for joining us today. And maybe just the last 4 concluding summary statements that hopefully everyone has appreciated really for pre-diabetes, what the implications are for, in terms of diagnosis, management, and follow-up. I think it's important always to try to focus on positive side of things, really to help support our patients to change their lives and motivate them for the benefits, really. We all know that really lifestyle intervention is the first line we should always try, and it's really about how we sort of individualize that advice for our patients, and subsequently really metformin can be added as appropriate to those with the risk factors to push them on from pre-diabetes to diabetes. And I think really we do hope that everyone can help really to follow up the patients and manage the relevant risk factors and comorbidities. So hopefully this will help us to double down on our war on diabetes and prevent all these patients from even reaching the diagnosis. So with that, thank you once again to Abel and Meng, and thank you everyone for joining us on the Saturday afternoon. All right, thanks everybody. So finally, I think there's a QR code here that ACE would really like to get your feedback on. So please do scan the QR code and provide feedback to ACE so that they can hopefully improve sessions all the time for every one of us. Yeah, thank you very much.